is my great pleasure at this point to introduce our speaker for today. Dr. Oluwatosin Adeyemo is devoted to providing excellent obstetrics and gynecologic care to women. She was born and raised in Ibadan, Oyo State, Nigeria. She graduated with a Bachelor's of Science degree in Biomedical Engineering and her medical degree from Yale School of Medicine, completed her residency in ONG at Harvard, where she received multiple awards for teaching. This is a core, this is something she loves to do at her core. In the next slide, we'll see some more details about her. In 2020, she completed a Master of Public Health degree at Yale. She's currently faculty at the Department of Obstetrics at Gynecology and Reproductive Sciences at Yale University. Dr. Adeyemo is passionate about addressing women's health disparities in the community and global settings through research, education, and provision of clinical care. She provides education and capacity building trainings to healthcare workers in local and global settings. She's also passionate about engaging with people at the community level in order to improve health outcomes through education and empowerment. She has engaged in research, teaching, clinical care in many parts of the world, including Nigeria, Senegal, Ghana, Uganda, and the United States. We are privileged and really honored to have her speak on this topic today. And so I'm going to stop sharing the screen and hand over and warmly welcome Dr. Adeyemo. Dr. Adeyemo, you're on mute.
Good afternoon, everyone. Can you hear me? Thank you for the introduction, Dr. Njoko. It's a pleasure and an honor to be here with everybody today. We're going to jump right into the conversation. So first, starting with an overview. Today, my goal is to provide an overview of COVID-19 in pregnancy, then move on to an overview of COVID-19 vaccines, particularly in pregnancy and among breastfeeding women. And then lastly, go over vaccine recommendations and considerations to date. I have no conflicts of interest to disclose. So the COVID-19 vaccines in pregnancy for breastfeeding women, is an evolving topic and could be a controversial topic, for different people and in different sectors based on people's experiences and beliefs about the vaccines. And my goal for today is to provide us as healthcare workers with information about the COVID-19 vaccine that we know of that up to date, being aware that the information continues to evolve, and as time goes on, we will get more information, but also to stress that the patient's choice is at the center of this discussion. And our goal as healthcare workers is to inform our patients, provide them with accurate, up-to-date information, and leave it up to them to make the choice that's best for them and for their situation. So first of all, going over COVID-19 in pregnancy, as most of us know, the pandemic, really started December 2019 in China, and became a global pandemic, was established as that, early in 2020. And so for over a year now, there's actually been information that has been gotten on COVID-19 among pregnant women. So I'm going to start with data from the United States Center for Disease, CDC, Center for Disease and Control. And this is data from January 22nd to October 2020, where they have surveillance data on women who were diagnosed with COVID and of those women, they had data on those who were pregnant and those who were not pregnant. And their data shows that pregnant women are more likely to have negative and adverse outcomes when they're infected with the SARS-CoV-2 virus that causes COVID-19 when compared to women who are not pregnant. Some of the severe outcomes that they outline in the results include the fact that pregnant women are more likely to be admitted to the intensive care units compared to non-pregnant women. And as you can see here, for pregnant women, the rate is 10.5 per 8,000 cases for pregnant women versus 3.9 per 8,000 cases for non-pregnant women. Also, pregnant women were more likely to receive invasive ventilation. So that means they were more likely to be intubated. Pregnant women were also more likely to be on ECMO, which is a device that is really reserved for severely sick people, and it's essentially a lung and a cardiac heart bypass. And pregnant women were more likely to be on ECMO when they were diagnosed with COVID-19 versus women who were not pregnant. And then ultimately, pregnant women are actually more likely to die compared to non-pregnant women in this cohort, based on data in the United States. Going to global settings, I would like to focus on the study that was recently published in JAMA Pediatrics, where they also had a group of women who were pregnant, and they compared them to, they had women who were diagnosed with COVID-19 and women who were not diagnosed with COVID-19, but who were also pregnant. And they compared the risk of morbidity and mortality among these two groups. And this was a multinational cohort study that included many countries, including Nigeria, Ghana, the US, Italy, and other countries around the world. And in the results, they show the outcomes of about 700 women in their study who were pregnant and who were diagnosed with COVID. And they compared that to about 1,400 women who were pregnant but they don't have COVID. And they compared the outcomes of those two groups. And I'm going to go over their data. So as you can see from this slide, there was also a higher rate or risk of morbidity and mortality for pregnant women diagnosed with COVID when compared to pregnant women who were not diagnosed with COVID. And so on the right-hand side of the slide, you can see that I highlighted the relative risk. And so this means that when the risk is 1.0 or above that, it means it's a higher risk for that population. So if we start, for example, with just overall maternal morbidity and mortality, the relative risk was 1.54. So that means that women with COVID-19 diagnosis in pregnancy had a higher risk of overall morbidity and mortality when compared to women without COVID. We can move on to, the data also shows that for pregnancy-induced hypertension and preeclampsia, women diagnosed with COVID in pregnancy also had a higher risk of having these two serious conditions when compared to women who did not have COVID in pregnancy. Preterm labor, the risk was 1.2, also higher. Similar to the data that I shared about the CDC data in the US, pregnant women with COVID were at a 5 times, the relative risk of being admitted to the ICU was 5.04. And they also spent more time in the ICU. Similar also to data that I mentioned in the US CDC data, maternal death, the risk of maternal death was 22 for women who were diagnosed with COVID in pregnancy. Going on to neonatal outcomes, so fetal distress, there was a higher risk of fetal distress in pregnant women who had COVID. Also, higher risk of cesarean deliveries as well in pregnant women who had COVID. Higher risk of preterm birth in women who had COVID. So overall, this table shows that on many outcomes for morbidity and mortality for moms and for babies, COVID-19 diagnosis in pregnancy was more severe for women with COVID than for those who didn't have COVID. Now, zeroing down on the risk of preterm delivery, still on their data, this graph, I'm going to go over this graph. So on the y-axis, it's individuals who remain pregnant, the percentage of individuals who remain pregnant. And on the x-axis is the gestational age. And as most of us know, term is defined as 37 weeks. Any delivery before 37 weeks is preterm. And I want to zero in your attention to this bright blue, turquoise blue graph right here. And this denotes women who were symptomatic from COVID-19 diagnosis. So they were pregnant, they had COVID-19, and they were symptomatic. And as you can see here, if you assume that this is 37, this is 35 weeks. If you go up on this graph, you can see that women who had COVID-19 diagnosis and were symptomatic, there were less of them were still pregnant at 35 weeks compared to women who were not diagnosed with COVID-19 in pregnancy, which is the dark blue line, and then the orange line, which is women who were diagnosed but who were not symptomatic. This graph also shows the reality that, not every woman who's pregnant who has COVID-19 does get severe symptoms. Actually, most people don't have severe symptoms requiring ICU admission. However, there is a significant portion who do have severe symptoms. And for those who have severe symptoms, they're more likely to have these negative outcomes. So now, what are the risk factors then for having moderate to severe symptoms from COVID-19 disease in pregnancy? Going back to the data, national data from the US CDC, this is data from March 29, 2020 to January 8, 2021. And they show that older age was a risk factor for having moderate to severe or critical illness with COVID-19 in pregnancy. And when I say older age, it really isn't that old. It's really, above 30, above 35 years old. Being Black, non-Hispanic race or ethnicity was a risk factor for moderate to severe illness. Of note, given that this data is in the US, where you have people from other ethnicities and racial groups, however, in Nigeria and in sub-Saharan Africa, where we're having this talk, obviously most people were not, being Black, non-Hispanic is not a minority race, it's actually the majority. And you could also argue that there may be, other factors that are associated with being, a minority, being Black and non-Hispanic in the United States compared to other parts of the world. However, data does show that, being not Black and non-Hispanic was a risk factor for severe illness. Being a healthcare worker was also a risk factor for severe or critical illness. Of note, during this time, March 29 to January 8, many healthcare workers, while most people were in quarantine, were actually actively still caring for patients being exposed to COVID-19 in their, among the patient population. And if we translate this to the general population, I see that being a healthcare worker could actually be a proxy for just risk of exposure. So as healthcare workers are at risk for exposure to COVID-19, so are also other professions, right, that place people at higher risk for being exposed to COVID-19. For example, people who are in the market, who are still in the market, who are exposed to, a lot of people who don't have the opportunity to quarantine. You can think, or to self-isolate rather, or to socially distance. Or you can think about people who, who are, maybe work in transportation services, work in motor parks, or work, where they have also close contact to people from different parts of the country, on the line of their work. Other risk factors for moderate to severe illness include people with underlying medical conditions. So pre-pregnancy obesity, and we know that obesity is defined as a BMI, body mass index of 30 and above. chronic lung disease, and that includes asthma, people with chronic hypertension, people with chronic high blood pressure, people with cardiovascular disease, and people with diabetes. So this brings me to the core of our talk today, the COVID-19 vaccines. Now that we have gone over the established fact that pregnant women are at higher risk of being sick, critically sick, from getting infected with COVID, or with SARS-CoV-2 virus and getting COVID-19 diagnosis, vaccines are out there that actually are known and have been found to reduce the risk of getting infection and or getting ill from an infection. There are many vaccines that are already in development and many that are still being developed, but I'm actually going to focus on the vaccines that have been approved by the WHO, the World Health Organization, on their emergency use listing. And the WHO, as we all know, is an international organization and with a track record of global and public health safety. And for vaccinations or medications that are approved by the WHO emergency use listing, the WHO has a panel of experts that review data and information before they approve these medications or these vaccines and place them on their list. I'm going to start with the Oxford AstraZeneca vaccine, mainly because this is a vaccine that I know that's already in Nigeria, being administered in Nigeria and other parts of sub-Saharan Africa. And this vaccine was developed by the collaboration with the University of Oxford and AstraZeneca, and the partnerships with the Serum Institute of India that manufactures some of the vaccines, and then some of the other vaccines are manufactured by South Korea, and a pharmaceutical in South Korea. And the vaccine was manufactured using a replication-incompetent chimpanzee adenovirus vector. So this is a virus that causes a common cold in chimpanzees and is overall safe in humans. And in order to get approval, in order for this vaccine to be approved, clinical trials were actually performed where the vaccines were tested in humans to ensure that they're safe and that they are effective in preventing infection from COVID-19 or COVID-19 disease severity. And in the clinical trials for the Oxford AstraZeneca vaccine, they enrolled about 24,000 people. And this was a trial that was done in the UK, in Brazil, and they also had some phase 1 and phase 2 trials in South Africa as well. And their clinical trials showed 70.5% efficacy of the vaccine in preventing severe COVID-19 illness. Of note, in this clinical trial, pregnant women were excluded. And that obviously is a limitation in their data. And this is also applicable to all the vaccines that are currently approved. However, as we'll talk about later on, there are many pregnant women who have gotten COVID-19 vaccines subsequently, and more data is going to be coming out on the effects of the vaccines in pregnant women. But based on what we know so far about the components of the vaccine, there is no evidence to think or to show that these vaccines would actually be adverse for pregnant women. However, the caveat is that more data is to come on the effect of COVID-19 vaccines on pregnant women. Going on to the time of administration, as most of us know, for the AstraZeneca vaccines, there are 2 doses given, 4 to 12 weeks apart. And more data is also showing that really the longer the intervals between the doses, the better the efficacy actually. So the 8 to 12 week interval dosing actually has been found to be more effective in boosting immune response to the vaccine. And the AstraZeneca vaccine is stored between 2 to 8 degrees Celsius. And this actually makes it very attractive for low-income countries like Nigeria, where because basically these conditions are like your refrigerator, settings. And so it makes it easier for handling storage in low-income countries. Other vaccines that have also been approved by the WHO and are circulating in higher levels in other parts of the world are the Pfizer vaccine, which is an mRNA vaccine. And in their trial, they enrolled 45,000 participants. And of note, for these clinical trials, what typically is done is that half of the participants get the vaccine and the other half get a placebo. And then the outcomes are tested among the two groups. And the efficacy was actually 95% for the Pfizer vaccine in preventing symptomatic COVID-19 infection. Also, pregnant and breastfeeding women were excluded from the vaccine. However, for the Pfizer vaccine, there were actually 23 participants who were pregnant and who got the vaccine, and 12 of them got the vaccine, 11 got the placebo. And then for the Pfizer vaccine, it's also given in 2 doses, but 3 weeks apart. But you can see that it's really stored under very cold conditions, minus 70 degrees Celsius. That's freezer conditions, and that is a limitation for availability in low-income countries. Next is the Moderna vaccine, also a similar mRNA vaccine, where 30,000 participants were enrolled in the clinical trials, and the efficacy was found to be about 94.5%. Similarly, pregnant and breastfeeding women were excluded from the original trials. However, about 13 participants were eventually exposed to the trials, and 6 of them got the vaccine, 7 had the placebo. And the Moderna vaccine is given in 2 doses, also 4 weeks apart, also stored under relatively colder conditions at minus 20 Celsius. I would note that for the Pfizer vaccine, even though in the original trials, pregnant and breastfeeding women were excluded, Pfizer is actually currently running a clinical trial that involves pregnant women that started either in January or February of this year. And so more data will be provided based on clinical trials of this vaccine on pregnant women. And then lastly on this table, the Johnson & Johnson vaccine that is based on the replication incompetent adenovirus vector, where 40,000 participants were enrolled, and there it was found to be 66.9% effective in their trial. And similarly, pregnant and breastfeeding women were excluded, but also there were about 4 people in the original trial who actually were pregnant who got the vaccine. And this is a 1-dose vaccine, which is also attractive for certain people and in certain situations where there could be more of a logistical issue in actually getting people to complete the 2nd dose. Other vaccines approved by the WHO emergency use listing is the till date is a Sinopharm vaccine. This is a vaccine that was developed in China. This is one of the 2 vaccines that they have currently developed. And the Sinopharm vaccine is an inactivated virus. So they have the SARS-CoV-2 virus that they inactivated in the lab, and then with inactivation, the virus is safe, and then it is administered. It's also a 2-dose vaccine, 28 days apart. And like I said, there are vaccines that are actually currently developed that are being administered in other parts of the world, and there are more that will be coming in the next couple of months to years. So what are the international organization recommendations regarding the COVID-19 vaccines among pregnant women? So the World Health Organization recommends the vaccination of pregnant women when the benefits outweigh the potential risk. For example, pregnant women at high risk of exposure to COVID-19 or with comorbidities that place them in a high-risk group for severe COVID-19. Another organization, the American College of Obstetricians and Gynecologists, recommends that pregnant individuals have access to COVID-19 vaccines, and that COVID-19 vaccines should be offered to lactating individuals. So these are women who are breastfeeding, similar to non-lactating individuals. Of note, in the United States, the vaccines that are available are currently and are approved are the Moderna, the Pfizer, and the Johnson & Johnson vaccine. The AstraZeneca vaccine has not yet been approved by the FDA for use in the United States. The Society for Obstetricians and Gynecologists of Canada, and in Canada, AstraZeneca is actually in circulation and is being administered. they support the use of all available COVID-19 vaccines approved in Canada in any trimester of pregnancy and during breastfeeding. One more, organization and country that I would like to highlight is what is being done in the UK, and mainly because, the AstraZeneca vaccine, obviously based, in the United Kingdom, is also highly circulated in Nigeria at the moment. And so according to the Royal College of Obstetricians and Gynecologists and other organizations in the UK, they show that as of April 28, 2021, over 22 million of people in the United Kingdom have received their first dose of the AstraZeneca vaccine, and nearly 6 million have received their second dose. Of note, there have been reports of about 240 cases of serious blood clots after vaccination, but these are actually very rare cases, about 11 per million cases. So this is a very rare side effect. And the UK government advised that individuals under the age of 40 be offered an alternative vaccine to the AstraZeneca vaccine. And keep in mind that this term is offered. So pretty much the UK government advises that people should be given the choice of what vaccine they want to take based on the information that's available. And pregnant women, the Royal College of OBGYNs state that pregnant women should be offered the Pfizer or Moderna vaccines. Although these recommendations are unique to the UK, I mentioned earlier about how Canada, where AstraZeneca is also in circulation, have sort of a different recommendations regarding the AstraZeneca vaccine. But overall, the overwhelming recommendation is that pregnant women should be offered available COVID-19 vaccines, the ones that have been approved, in the countries where they have been administered, and they should be provided with information about risks and benefits of the vaccine, but also importantly about the risk of COVID-19 in pregnancy, and they should weigh their own particular risk factors for infection and for severe illness. And with that information, they should make an informed decision of when to get the vaccine, whether or not to get the vaccine, and which vaccine they should get. So there's a decision aid that I found very helpful, and there are many out there, but there's one that was developed by the University of Massachusetts that I would like to share. And I think it's helpful as healthcare workers to go over something similar to this with our patients as we counsel them. So the question is, how do I decide whether or not I should get the vaccine? How do I weigh my risk? And on the left side is the green column, talks about the risk of getting sick from COVID are higher if you have contact with people outside of your own. So if you think about Nigeria, Sub-Saharan Africa, if you're a market, if you work in the market, if you work in a motor park, if your job, if your occupation puts you at very close contact with a lot of people outside of your own. If you're 35 years or older, if you're overweight, if you have other medical problems like diabetes, high blood pressure, or heart disease, if you're a smoker, if you're a racial or ethnic minority, or your community has a high rate of COVID infections, or if you're a healthcare worker, it probably makes sense to get the vaccine. On the right hand of the column, on the right hand of the screen, if you are not at higher risk for COVID and you always wear a mask, you and the people you live with can socially distance from others for the whole pregnancy, your community does not have a high or increasing COVID cases, you think that the vaccine itself will make you very nervous, you're more worried about the unknown risk than about getting COVID. Or if you have had a severe allergic reaction to a vaccine, it might make more sense for you to wait to get more information. So other need to know information for healthcare workers as we counsel patients about COVID-19 vaccines. The WHO does not recommend pregnancy testing prior to vaccination. The WHO does not recommend delaying pregnancy or terminating pregnancy because of vaccination. And the vaccines do not cause recipients to have COVID-19 disease. I want to share briefly information about the COVID-19 vaccines among pregnant women based on data in the US. like I mentioned, actually the US has been vaccinating women with COVID, people with COVID, vaccinating people against COVID-19 infection since December. And so up to date, and the US CDC has a tracking system. They have a surveillance system called vSafe, where if you got the vaccine and you're pregnant, you can actually register to participate in the surveillance system, and you can let the CDC know what your symptoms are, how things are going for you, how your pregnancy has been going so far, after getting the vaccine. And so based on the vSafe vaccination health checker, as of May 10, 2021, about 110,000 women who have gotten the vaccine report being pregnant at the time of getting the vaccine. The CDC has registered about almost 5,000 of those women into their surveillance program, and they are tracking those women till date. So you can see from this that a lot of pregnant women in the US have gotten either the Moderna, the Pfizer, or the Johnson & Johnson vaccine till date. And then lastly, I want to briefly go over data that was recently published by the CDC on the group of women who registered for the surveillance system and who got the vaccine in pregnancy. And they compared the symptoms of these women with the symptoms of women who were not pregnant. And it shows that women who were pregnant who got the vaccine actually had similar symptoms. So women who are pregnant are in the other dark blue, and the lighter blue or the gray are the women who are not pregnant. And the symptoms from the vaccine after getting the vaccine were similar across the group: pain, fatigue, headache, body aches, chills, and fever after the first dose. And then after the second dose, obviously these symptoms were a lot more. Of note, these are symptoms that usually on average occur for about 24 hours after the vaccine, and they resolve. Some people have the symptoms for a little bit less, some have it for a little bit more, maybe maximum of 3 days. When I got the vaccine, I got the Moderna vaccine, I actually had the symptoms for, I would say, almost 3 days. However, there are symptoms that resolve, and there are also symptoms that are not a sign of the recipient being sick. Pretty much it is the body's response to getting the vaccine. And I want to note that even though fever is a known like a side effect or response after getting the vaccine, it's overall, we usually recommend that women who are pregnant and anybody who actually gets the vaccine who has a fever, that they can take paracetamol, fever reducing agent, in order to reduce their fevers. We know that fevers are not, sustained fevers are not encouraged in pregnancy, because we know that particularly in the first trimester, high fevers increase the risk of adverse neonatal outcomes if it's sustained among pregnant women. However, till date, there is no information nothing has been shown that these fevers have caused any negative outcomes on the fetuses or the infants of women who have gotten the vaccine. And also of note, there is no recommendation to delay, getting the vaccine, during the first trimester, for women who want to get a vaccine who are pregnant. However, some people a consideration that some people have is they may decide that they want to get the vaccine maybe in the second or third trimester to avoid having fevers. However, this is not a strong recommendation, and women are actually encouraged to get the vaccine at any time during their 3 trimesters of pregnancy. So one last study that I wanted to share was a small study based in Boston, where they actually had a small group of women who actually already got the vaccine and then had a baby. And in their study, they found out that women who were pregnant and got the vaccine, they actually had a higher antibody response. So they had more antibodies produced to protect them compared to women who had antibodies from a natural infection. So this supports the fact that even in women and people who already have COVID-19, who have been diagnosed with it in the past, it's still recommended that they consider getting the vaccine when offered to them. The study also showed that in this study, they examined the umbilical cord and the breast milk of women who were vaccinated. And they actually found out that there were antibodies present in the umbilical cord and in the breast milk. So this is, the extrapolation is that these antibodies are also being transferred to the infants, to the babies. The data on how much that protects the babies is still unknown. The data about how much levels of the antibodies were in the babies, that wasn't in this study. But as more studies and as more time passes, we will also have more information on, how much of these antibodies are passed on to the infants, and also how much it protects them or does not protect them. So take-home points. The COVID-19 diagnosis can cause severe adverse health outcomes for mothers and babies. Vaccines reduce the risk of severe illness from COVID-19 disease. Data to date shows that the approved COVID-19 vaccines are safe in pregnant and breastfeeding women. However, the caveat is that more data is emerging, and our data so far is limited by time, but as time goes on, we're going to have more information. And lastly, it is our duty as healthcare workers to stay informed and to provide our pregnant patients and breastfeeding patients with correct information for them to make an informed decision. And resources that as healthcare workers we can rely on: the World Health Organization, the different OBGYN organizations in our countries, for example, Royal College of OBGYNs, the CDC, Canadian, College of OBGYNs. And that's it. And I'll open it up to question and answer.
You do have a number of questions and questions in the chat room, Dr. Adeyemo, but thank you very much for your brilliant presentation. I'm going to jump right in. I know we have some minutes to discuss, and then we'll go over to the case presentation while you go through the chat answering the other questions. And so we have a question here. I have a question. Nothing was said about the women who were inadvertently exposed while pregnant and they took the vaccines. What was the outcome? Did it affect them?
Yes, thank you for that question. Yes, so many of those women have actually given birth already, and based on the data from those trials, and even from the women who we know have gotten the vaccine so far, who were not even part of the trial. So for example, the CDC data that I showed, out of over 3,000 women in their registry, about 700 of those women have already given birth to live-born infants. And so far, there is no data that shows that the vaccine negatively affected the fetuses or the infants. There is no data that shows that there is a higher risk of miscarriages among those who had the vaccine and those who didn't. So really the overwhelming data that we have, the overwhelming and limited data that we have so far shows that there has been no negative outcomes to the fetuses or to the mothers, different than the negative outcomes that women have, women could have at baseline in pregnancy.
Okay, and the same participant also says, I had a doctor who took the vaccine and developed all manner of facial nerve palsy that led him to be hospitalized for over 2 months. He's currently better and undergoing physiotherapy. In the light of this, should we really advise pregnant women to take this vaccine?
So, with any vaccine, with any medication, there's always the risk of adverse, reactions. And there actually have been very rare cases and reports of such similar adverse reactions in people who got the vaccine, both people who are pregnant and who are not pregnant. And millions and millions of the vaccines have been administered around the world. Or I guess probably not around the world, in the US, obviously Nigeria and other parts of the world. And really the overwhelming data has shown that the rate of those rare illnesses, they're very rare. Most people who've gotten the vaccines, have done well. I showed you the slide the fatigue, and those are common, relatively resolved very quickly, without significant intervention. And so based on the data, I would say that I would advise pregnant women to be aware of the common side effects, and to then, based on their risk factors of being infected, based on their comorbidities, decide whether or not they want to get the vaccine. I also am very careful when I get stories of like anecdotal stories of somebody who had an illness after a vaccine, because I also don't know what the whole situation, right? We don't know, did that person have another condition that predisposed them to, was there something else going on other than the vaccine that caused that to happen? And that's where the role of the clinical trials are important, because with clinical trials, you can actually control sort of, the conditions and get to see the safety of the vaccines. And so far from the data from thousands of people who have been enrolled in the clinical trials, the vaccines are overall safe.
Okay, so we're also monitoring, please. So if you want to be given the opportunity to unmute yourself and speak, please do raise your hand so that we can give you the opportunity. We have a question asking if Pfizer and Johnson & Johnson are recommended for pregnant women and breastfeeding mothers.
Yes, so Pfizer and Johnson & Johnson are on the WHO emergency use listing, and they are, and the WHO recommends that pregnant women and breastfeeding women, be offer the vaccine and for them to weigh their risks and benefits, whether or not to take it. In the United States, where Pfizer and Johnson & Johnson are, and also the Moderna vaccine are, in high circulation, the OBGYN organizations here, ACOG, SMFM, which is a high-risk OB organization, they actually, strongly recommend that pregnant women and breastfeeding women be offered the vaccine and receive the vaccine. So the answer to that question is, it is recommended that they should be offered the vaccine and that they should receive the vaccine.
Okay, so we have another question, related to the women who did inadvertently receive the vaccines during the clinical trials. Do we know more about the demographics?
So yeah, we don't know about the demographics. However, I want to say that even after the clinical trials, like I mentioned again, the CDC just published data that they have data so far about 700 women who they confirmed got the vaccine, and actually when they were pregnant, most of them got it in the 3rd trimester, and they actually already had their babies. And the data from the CDC, there was actually like a mix of the demographics of women who got the vaccine. I don't have the number on top of my head, but there were basically women in anywhere from like I don't have the demographics, but they were basically what you would expect in like your average pregnancy population, pregnant population women.
Mm-hmm.
Yeah.
Yeah. Okay.
And they were representative of the US population overall.
Yeah, so we have a question, and we've even had one member of the RICOM 3 project team who was declined, at the vaccination site. She was refused taking the vaccine because she was breastfeeding. And so we have one healthcare worker here on the line asking the same, currently breastfeeding. This is a healthcare worker. How safe is the vaccine for me and my baby?
Yeah. So based on the information we have today, the vaccine is safe for pregnant women and breastfeeding women. And if you recall the data that I showed about the very small study, the Boston study, where the umbilical cord of women who got the vaccine was analyzed, and they actually had antibodies in it. And really, it's actually great when antibodies are transferred from mothers to babies, because we know that, like for example, other conditions like for whooping cough, for tetanus, we know that we recommend vaccines for pregnant women because we actually want them to transfer those antibodies to their infants, so that their infants get early protection before the infants can then get their own vaccination. And so a benefit of potential benefit of breastfeeding and getting the vaccine is that you can potentially also, in addition to protecting yourself, potentially be protecting your baby as well. However, like I mentioned, the caveat is that there are more studies that are going to be coming out soon about actually how much the antibodies in the breast milk protect the baby, how much is in the breast milk. So that's still ongoing information. But I would say consider your risk factors. Consider your risk of getting COVID infection based on either where you work, where you live. Consider the rate of COVID-19 infection diagnosis where you live or where you work. Consider your risk factors. Are you somebody who is the person overweight? Do you have high blood pressure? Are you older? Do you have a risk of getting severely ill based on the risk factor that I presented to you? And then you make an informed decision. And I realize there's some people that will decide that, based on the information that I have, based on what we know so far, I will decide to wait to get more information before I make a decision. But then that is up to each individual, but also be aware of sort of the risk and benefits of also waiting, in line of what we also know about the potential severity of COVID-19 in pregnancy and in breastfeeding.
I think we can squeeze in one more question, and a verbal question/comment from Sumte Bezi. I see your hand up, but we have one last question on the chat. What trimester is best for the vaccine to be taken?
That's a great question, as all the questions that have been raised. There is no specified trimester where, we would say it's best to take it on one trimester versus the other. Based on, people's risk factors for exposure, it's recommended that they get it anytime in pregnancy. However, like I mentioned earlier, fevers are, known side effects of the vaccine, particularly in the first couple of hours. And, it's overall safe to take paracetamol in pregnancy in order to reduce the fevers. And so, for people who take the COVID vaccine in the first trimester or any trimester who have a fever, take paracetamol to reduce that fever. Some people consider that, given that in the first trimester, the first 12 weeks, that is when organogenesis really occurs. That's where organs are being formed. And that is also a very I would say, sensitive trimester where, the baby is in development is sensitive to, exposure to potential risk. Some people decide that because of that, they may decide to not get the vaccine in the first trimester and then wait till the second and third trimester. But that is not set in stone. And also keep in mind that there are people who also can get the COVID-19 diagnosis actually affected in the first trimester. And so if you're somebody who, even in the first trimester, you are at high risk of getting COVID-19 diagnosis or being infected with the virus, based on your situation, you might decide to still get it in the first trimester. So the summary is that you can get it in any trimester, weigh the risk and benefits, weigh the information you have, and make a decision.
Okay. Thank you very much, Dr. Adeyemo. You have some more, just keep monitoring the chat and chatting in other answers to questions that may still be popping up. Somto, if you'd like to unmute yourself and speak, 30 seconds. Can we unmute Somto Ibezi? Okay.
Hello, good morning, good afternoon, everybody, depending on where you are. Thank you, Dr. Adeyemo, for the fantastic presentation. Thank you, Kendra, for inviting me and making sure that I attended today. Thank you. My comment is more of a comment and a reflection point. So I've had family members who are pregnant on the way in Nigeria, in Abuja, from getting the COVID vaccine. And this is after I had pushed and finally convinced them to. But I would assume, because the person is non-medical, maybe they didn't go into explaining why she shouldn't have it to her. But I'm just wondering if someone can throw some light on the data that this recommendation is based on for denying these pregnant and breastfeeding moms COVID vaccine, a life-saving vaccine, really. Is it based on any data, or are we as healthcare professionals transferring our biases to these patients, which shouldn't be so. We might have some reservation, but I think we should base our decisions on ethically done research. So I'm just wondering if there's any data that people have used to convince pregnant women and breastfeeding moms not to get this, or is it just healthcare professionals transferring their own biases to the patients? Thank you.
I'll leave that question to my Nigerian colleagues to speak on what is the Nigerian OBGYN society, what is being recommended by the society, and also what like was the question was asked. I'll have you answer that question.
Yeah, okay. Thank you very much. So Dr. Ogu is going to come up to make his presentation now on the management of a pregnant woman with COVID-19 infection. But please, let's carry on the discussion in the group. I would like to invite Dr. Museni, who is a renowned obstetrician and gynecologist in working with the Lagos State Ministry of Education, to please address this question or some of those reflections in the chat. Sometimes if you could put that reflection in the chat, that would be great. And I'd also like to invite Vivian, who is also on the call, to please also add her thoughts to those questions about known research and what is the advice coming out of the the Ministry of Health in Nigeria on that topic. And so going to hand over the reins quickly to Dr. Ugu, who is going to, over the next 8 minutes, 7 minutes, just share with us about one of the cases they handled at University of Lagos Teaching Hospital.
Okay, good afternoon, everyone.
Good afternoon, we can hear you clearly. If you could just put your slide in presentation mode.
Okay.
Thank you.
Okay, done.
And just a reminder to Dr. Adeyemo to please answer further questions in the chat. Dr. I'll go over to you.
Okay. So can I go ahead now?
Yes, it's still not in presentation mode, but we can see. So go ahead, please.
As I said earlier, I'm making a case presentation of a pregnant woman pre-diagnosed COVID-19 that was managed at the teaching hospital sometimes in April. She presented to the teaching facility. She's a 33-year-old female civil servant married in her 5th pregnancy at 35 weeks of gestation. She presented with cough, fever, and difficulty in breathing of about 5 days duration. So she presented to LUTH following a referral from another private facility where ab initio she was being managed for upper respiratory tract infection. Presentation, the fever was said to be high grade and continuous, productive of rotty sputum, but not blood stained. She also had bilateral leg swelling, but no history of orthopnea or other fatal symptoms. So she had no history of recent travel. Neither did she have any contact with any confirmed case of COVID-19, and she's not a health worker. She's non-asthmatic. So in the private facility, she was ab initio being managed for acute severe asthma with supplemental oxygen, salbutamol, and other medications, including parenteral antibiotics. So despite treatment, her symptoms worsened, and then that necessitated other investigation like chest radiograph, which showed features of atypical pneumonia suggestive of COVID-19 pneumonia, and then acute pulmonary edema, because of which a rapid PCR was done for her for COVID-19, which came out positive after 48 hours on 17th of April 2020. And then because of that, she was subsequently referred to LUTH for expert care and then delivery of her baby. This index pregnancy was planned, desired, and spontaneously conceived. And then it was detected at 4 weeks following a positive urine pregnancy test after a mixed period, then confirmed with ultrasonography at 8 weeks. So she booked for antenatal care at the referring facility, and then her pregnancy has been uneventful till the time of illness. And though in her previous pregnancy, she had a cesarean section for fetal macrosomia. On admission at LUTH, she still had difficulty in breathing with features suggestive of respiratory failure. Her respiratory rate as of then was 76 beats per minute. And then her oxygen saturation was 76% at room air. She was commenced on treatment for acute pulmonary edema, giving Lexis, furosemide, and then other supportive therapy for acute severe asthma. So she was initially admitted into the isolation ward, but because the symptoms worsened, the multidisciplinary team then agreed to admit her at the high dependency unit of the hospital. So despite admission into the high dependency unit, she had a sudden deterioration of her clinical symptoms. And then on the second day, her respiratory rate was 50 cycles per minute, and oxygen saturation kept decreasing despite being on 15 liters of oxygen. It was about 88% on why, despite being on supplemental oxygen. Though all the parameters of the fetus were normal, even the fetal heart was about 152 to 156, and amniotic volume was adequate on bedside ultrasonography. And then a decision was made by the multidisciplinary team to deliver her via emergency cesarean section. And indication being pulmonary edema, respiratory failure, and then hypoxic respiratory failure. So she was then delivered on that same day of a preterm fetus at 35 weeks, 2 days. The baby weighed 3.5 kg, though had a good ABDA score. So her post-operative oxygen saturation was between 96 and 97, while she was still being maintained on 15 liters of oxygen via adult face masks in a reservoir bag. So the baby, after resuscitation by the neonatologist, was returned to the mother, and they were being nursed in the recovery room of that delivery suite that was designated for the COVID-19 pregnant mothers. So the newborn was commenced on breast milk when the mother was stable, and then baby was fed on demand. She was not mainly in sitting position because her respiratory failure, she could not tolerate any other position aside from the sitting position. So on the 5th day post-op, the multidisciplinary team, after review, decided to wean her of oxygen gradually. But despite that, that weaning off of oxygen resulted in critical hypoxia and then postpartum collapse. She was then recommenced on oxygen. At this point, the hematologist opted to do the Hens bodies, which came out to nearly 100% of her red blood cell with precipitate hemoglobin with pastel violet. And then a decision was made to do a partial exchange blood transfusion in 2 sessions with these women with a total of 4 units of whole blood session that was used in the EBT. Subsequently, after the EBT, her oxygen saturation improved significantly, and she was then gradually weaned off oxygen till 17-day post-op from that 5th day. So after that, she was then transferred to the regular postnatal ward, having tested positive for COVID-19 PCR on the 7th day post-op. So at the end, during delivery, the nasopharyngeal swab was also taken from the baby, and at 48 hours and 1 week after delivery, which were all negative. So baby and the mother then remained asymptomatic from that postpartum period till 22nd day that she was discharged. And then throughout this period of care, both the nurses, the multidisciplinary team that managed her, maintained physical distancing at all points. And then aside from the time she was on oxygen, she wore face mask all through to avoid transmitting the infection to the other health workers around. And then following that, appropriate counseling was done to the mother and baby before she was discharged on the 21st day postpartum. And she was then scheduled for follow-up in 2 weeks. During her 2 weeks and 6th-week follow-up, the test was also repeated, which was also negative. And then she was counseled appropriately. So the other tests that were done for them, which in trial is at that 2nd week and 6th week, their samples, both the mother and baby, were also collected for COVID antigen and antibody, which is a study being done by the teaching hospital. Those still came.
Hello.
Okay. Talking more of the experience, because of the peculiarity of this case, in as much as she was managed for COVID-19, her symptom only improved despite the medication after EBT was done with 4 units of blood at 2 sessions. So that improved her oxygen saturation. So because of that, because of that EBT, an improvement on her oxygen saturation. It was a reportable case that was published sometimes in June 2020. Further to the Lute experience, we also checked those neonatal outcome of those mothers with the pre-diagnosed COVID-19 positive mothers. And then, because what were done to them, they were not done to other babies delivered at the same point, is that their cord blood were also collected at the point of delivery for a COVID antigen antibody. Their nasopharyngeal swab were collected at birth 48 hours and 1 week after post-delivery. And their placenta was sent for histology and immunohistochemistry for COVID antibodies. And then those were followed up as of this point when this was diagnosed. There was no case of vertical transmission of COVID-19 recorded so far in the hospital. And then all those women that were delivered, apart from the one that were actually very unstable at delivery, were encouraged to breastfeed their babies and do other postpartum care like other women, only when they've tested negative. Thank you.
Thank you so much, Dr. Ogo. Thank you so much. So monitoring the chat to see if there's any question for you, but I see that there's still a lot of some questions for Dr. Adeyemo. Please, to everyone on call, if you have any question for Dr. Ogo on the management of this lady with who is pregnant and had a COVID-19 infection, please do share that. I'm going to give a minute to Vivian to please speak on, what it is to respond to Somto on her question around, is the people who have been the pregnant and breastfeeding mothers who are being denied the vaccine, is that based on, advice given by the Ministry of Health in Nigeria, or is that personal, or are we having personal bias influence the decision? Is there any data supporting this refusal by healthcare workers in Nigeria? Cindy, can we make sure that Vivek can unmute herself?
Okay, thank you. Thank you, Kendra. I couldn't unmute myself, but thanks for unmuting me. Just to respond very briefly, that question, it's an interesting one and very important one about healthcare workers. I'll just start briefly by mentioning, we did a household survey early this year looking at perceptions of vaccines. And one of the places people get information about vaccines, especially in urban areas, is healthcare centers. But in rural areas, people get information about vaccines from outreach programs and from community workers. And this informs whether people know, especially healthcare workers, know about vaccines for pregnant women. So far, the unfortunate thing is there has been no clear directive from the Ministry of Health or MPHCDA saying whether vaccines are safe for pregnant women. So what we seem to see are healthcare workers are using their own personal judgment and assumptions about the safety of vaccines. And in addition, a lot of the studies that were mentioned during this webinar do not seem to be available to healthcare workers or, Ministry of Health mentioning them in Nigeria. So from what we know, a lot of it is based on personal judgment and assumption, and healthcare workers are probably just using their own biases and playing safe in refusing pregnant women from getting the vaccines, but there's been no clear directive as such about vaccines for pregnant women.
Okay. Thank you so much. Thank you so much for throwing light to that. So, Dr. Ugai, I think, yeah, go ahead, Dr. Adeyemo.
I'd like to add to what Dr. Hiekezu, I apologize if I pronounce your name wrongly. She made such, an important and valid point that, as healthcare workers, we all have our individual biases about, thoughts and opinions about this vaccine. However, it is our role, and it's important that we don't allow our biases to influence the care that we provide to our patients. And it's a prerogative, it's our responsibility to provide patients with information right? And have them make that decision. And so I think it's something that even, as a healthcare worker for me, on the flip side, even though, I think that the vaccine overall is safe, I'm also not going to force a patient who is not comfortable with getting a vaccine to get the vaccine. But then the flip side also applies, where even if as a healthcare worker, I am not comfortable with the vaccine, it really is the choice of the patient, and we should provide patients information for them to make an informed decision.
Thank you very much. I think that, that just ties everything in. We have a question here for Dr. Ugo. Apart from the EBT, was there any other medications administered to the patients?
Okay,
Doctor,
thank you.
yeah.
Yes.
Mm-hmm.
For the management of COVID-19 mothers, after admission, most of them, they must have registered for antenatal care elsewhere or at the teaching hospital ab initio, besides their routine antenatal medications, which they've been on since pregnancy. We administer drugs, most supportive therapy. We give high dose vitamin C, we give antimicrobial, depending on the clinical assessment of the patient. Then we'll give zinc and other medications that are specific to COVID. Why we're being very careful is that some people actually manage COVID-19 on their own. That's why it's not really advisable that you mention all the medications we use at isolation center in open forum like this. Other things are besides zinc, vitamin C, oxygen therapy in case the person is desaturating. We avoid giving ivermectin, which people mention. We never use hydroxychloroquine in pregnant mothers. The summary of it all is that usually supportive therapy, including antimicrobials, that will give those women. And then talking about the EBT, what have informed the choice of the EBT? The MDT made a decision for delivery of this woman because of her deterioration, despite being on 15 liters of oxygen. And then we believe that delivery of her baby as of that point will enhance maternal resuscitation and then improve her oxygen saturation, which happened within the first 48 hours. But then when we tried to wean her off oxygen on the 5th day post-op, she desaturated and even had a postpartum collapse. Then the other options were, because she was still cyanotic, after discontinuation of the oxygen. So we then decided to do her Hens bodies, which is actually the thing to find out the mutant hemoglobin she has in her system, which came out very high. And then that informed the decision of the EBT. After the first session with 2 units of blood, it was repeated and it was still high. We then repeated the second one, the second session with 2 units of blood. And it's then, after repeating the peripheral blood film, it was then better. And then her oxygen saturation improved. So we use both the laboratory and clinical parameters that's what guided the judgment of whether EBT should be done or not. We don't do EBT routinely for every mother. But this woman, because of the peculiarity of her case, she's been in a private facility for about 1 week where she was desaturating, and they thought it was asthma before she was referred to the teaching hospital. And that might have informed the choice why she didn't even respond to most of those medications, even after delivery of her baby. And then that's why we decided to do a peripheral blood film for her, which informed the decision for EBT. Thank you.
Okay, so in the last 1 minute, can you for everyone else on the call, so a couple of us joined earlier, we're having a most interactive session around many doctors just going straight to do an elective CS for women with no other indication other than they had COVID-19 infection. Dr. Okichukwu, could you just please in the last 1 minute, just throw some light around why doctors managing patients in Nigeria with COVID-19 infection are preferring to do elective cesarean sections versus normal delivery?
Well, I operated in the cesarean section of about 11 of those pregnant mothers. The challenge is that being a new disease, we believe that minimal contact with the patient will actually prevent the transmission of COVID-19 to the healthcare workers. And then for a woman in labor, none of them came in spontaneous labor, and we decided to do a cesarean section. But for a woman pre-diagnosed COVID-19 positive mother presenting at term, so if you check the risk of going for induction of labor, that you have to keep on examining the patient at regular intervals, which takes about, let's say, 8 to 12 hours. And then a cesarean section that you do between 30 minutes to an hour. Many of the obstetricians opted for cesarean section just to decrease the contact, especially that early period, to decrease the contact between the obstetrician and the COVID-19 positive mother. However, about 2 or 3 of them, I can't remember exactly, had vaginal delivery. 2 actually came in spontaneous labor. 1 declined cesarean section despite the counseling, and then we did induction of labor for her, and she delivered vaginally. So it's not something that is evidence-based that we have to do cesarean section for each of those women, but the peculiarity of trying to decrease the contact between you and the woman that is positive, which some of the obstetricians, despite every, even all the meetings and the training, refuse, that they will not even be part of the COVID-19 team. You, ab initio, would have accepted to be part of the team. You try as much as you can to decrease contact with that woman. Because if you operate the woman, for instance, you and your team that operated will be the person, an infectious disease team, that will see her to delivery. We also had issues that when those women have even tested negative, that they present to postnatal care after 2 weeks and 6 weeks, and even other senior registrars will even decline to see them, that they have tested positive ab initio, not that they are positive as of the time of presentation, 2 weeks or 6 weeks post-delivery. So those were not evidence-based, but it was just because of the fear among the health workers in this country. So that's why we opted for elective or emergency CS in most of them. Thank you.
Thank you very much. Yes, I'm looking at the time. Okay, 1 minute.
Just some vaccines among healthcare workers. Like the data showed, and like Dr. Ugu mentioned, it is a real concern as healthcare workers are exposed to COVID-19. And for me as a healthcare worker, that was one of the reasons why I actually decided to get the COVID vaccine, because I knew that I had a high risk of exposure with my work. And you could also think that when we're also more protected, then we can better protect our patients as well. So that's a plug to all of us.
Yes. Very, very, very valid contribution. So please don't run away. We want to really see the results to the quiz. So we're going to pop up the quiz again, and then Dr. Adeyemo is going to share the answers, and we're going to wrap up. So please just give us like an extra 2-3 minutes. The quiz is up, please, and it's okay if you didn't answer. If you joined after the pre-quiz, please still go ahead and share your answers. We have the first quiz in, waiting for more. Let's show Dr. Adeyemo that we were listening. Dr. Kendra, you're on mute. My apologies. So we have about 53% in. I'm just going to give 30 more seconds. Now 10 more seconds. Please don't drop off till we shared. We're just going to review the answers and tell you our next topic. And we all say a big thank you to Dr. Adeyemo. Okay, we're ending the poll right now. We had 60 people submit their answers. Can we end and share the results? Okay, so I'm going to read out the questions, Dr. Adeyemo, and you tell us true or false. Pregnant women are more likely to get severe disease and die from COVID-19 disease than their non-pregnant female counterparts. 85% of people say true, 15% of people say false. What say you?
The answer to that is true, and that is based on global data. In many countries, including Nigeria, Ghana, the United States, and even based on the case that was just presented to us on the case in Luke. Pregnant women who are diagnosed with COVID-19 disease are more likely to have severe illness, to be intubated, to be admitted to the ICU, and to die when compared to women who are not pregnant who have COVID-19 diagnosis.
Okay, so 85% of people got that correct. Risk factors for severe disease in pregnant women with COVID-19 include age of 35 or older, obesity, and or hypertension.
Yeah, it looks like
True or
most
false?
True. Most people got the answer correctly.
Wonderful. Studies have shown that COVID-19 vaccines are unsafe in pregnant women. True or false?
False. The data that we have so far shows that the COVID-19 vaccines are overall safe for pregnant women and breastfeeding women. The data is still evolving, and there'll be more information as months, weeks, and years come by. But what we have so far for the past year shows that it's safe.
So 93% of people got that correct. The following vaccine can be stored in the refrigerator, making it attractive for low to middle income countries. Which one?
The answer is actually AstraZeneca, and that is why it's widely available in Nigeria and in other low to middle income countries, because you can basically store it in the fridge, easier for better handling. Pfizer and Moderna, Pfizer is stored under -70 Celsius freezer conditions, and Moderna needs to be stored under -20. So the answer is AstraZeneca.
Wonderful. So most people got that correct as well. The AstraZeneca vaccine gives maximum protection against COVID-19 after the first dose.
Yes, so most people answered that has been false. So AstraZeneca vaccine is given in 2 doses, and the data from the clinical trials actually shows that when the doses are given 8 to 12 weeks apart, people actually develop a better protection, immune response and protection against symptomatic COVID-19. So the answer is false.
The answer is false. Okay, thank you very much. So we see that majority of people got all the answers correct. So can we just announce the topic for the next session? So our next session will come up. So the tele-education sessions for reproductive health series happens every third Thursday of the month. It happens at 2:30 to 4 o'clock every third Thursday of the month. And for next month, it will be on Thursday, 17th of June. The topic is predicting and preventing preeclampsia and eclampsia, early maternal warning signs. And we have a most seasoned speaker, Professor Tunji Adeniji, who is in one of our leading teaching hospitals in Nigeria, and he's going to be speaking on this topic. So looking forward to seeing you all there. And that brings us to the end of today's call. If you can quickly just chat in what topics you would like to see us cover, and on the screen, you can just take a screenshot of all our social media handles and turn on your notifications so you hear from us.